Tuesday, December 8, 2020. Welcome to the online ART training in Module 1B on Sperm Morphology. It is 9 a.m. Eastern Standard Time. My name is Ashok Agarwal, and I am going to be your host for the next 2 hours. We are here in Cleveland Clinic in Cleveland, Ohio, United States. Just a very short introduction to myself. I am the head of Andrology Laboratory at the Cleveland Clinic Foundation in Cleveland, Ohio for past 28 years. I'm also the director of the American Center for Reproductive Medicine. I'm a staff in urology at Cleveland Clinic. And I'm very proud that our team is rated as #1 in the world in the fields of male infertility, andrology, and human-assisted reproduction. This is based on the number of peer-reviewed publications, citation scores of people who are using our articles into their own publications, and an H-index. These together can be searched by anybody in any part of the world using Scopus. We have a large number of books in the area of human reproduction, and many more books are going to be coming in. And our laboratory has trained a very large number of scientists, clinicians, and graduates and undergraduates from the United States and more than 85 countries. So with these words, I want to welcome all of you who are attending the program. We are expecting a number of about 1,400, some numbers, and I think you will see in the slide who have registered. The capacity of WebEx platform, which is being used to air this program and reach out to all of you, is 1,000. Those who are not able to get in and who join a little bit late will be able to see this program live via the streaming link which has been provided on the WhatsApp. For declaration, the organizers and the speakers have no conflict of interest. No companies or outside entities were contacted for sponsorship. The program was made entirely possible by support from the Cleveland Clinic. Webcasting was supported by our colleagues David Reichling and David Wolfley from IT, who have generously supported our program last month as well. The course faculty have generously donated their time for this online training and have spent pretty much the entire 1 month preparing for this course, as you will hear. Program coordinators, we have a fantastic team of 9 coordinators from all different parts of the world who have generously donated a large amount of their time on a day-to-day basis for this training. The names, images, and description of certain products or instruments shown or discussed during the lectures in today's presentation are being used routinely by us in the Andrology lab. These items are not endorsed by any of us as speakers. So let's talk very briefly. The learning objectives of today's module is to develop an understanding of sperm morphology by WHO 5th edition, understand the staining protocol used in the laboratory, learn the use of strict criteria classification, understand the external quality control in sperm morphology, learn about, and there are many troubleshooting tips that we are going to So the next speaker is our colleague, Dr. Neel Parekh. Neel is a clinical professor in the Department of Urology in Cleveland Clinic. He is fellowship trained in andrology and male infertility, and he is specializes in the area of andrology. So he's going to be presenting now the next talk. So let us start his presentation. Neel's presentation is recorded because he is in the surgery today, every Tuesday. So, but he has done a fantastic job and you will enjoy it. So without any further delay, shall I mute it?
Hi, this is Dr. Neel Parekh. I am a clinical assistant professor in the Department of Urology at the Cleveland Clinic. In line with today's discussion on sperm morphology, I'd like to share my interpretation and clinical management of sperm morphology results. Today's lecture will consist of a series of 7 clinical questions. Let's begin with the first one. We have a patient who has a clinical grade 3 varicocele, a sperm concentration of 40.5 million per milliliter, and 60% motility with 2% normal sperm morphology. Should he be a candidate for varicocele repair? Now, for those not familiar with varicocele, a varicocele is a physical abnormality found in roughly 15% of men. When looking at patients with abnormal semen analysis, we found that varicocele is present in roughly 25% of this population. Now, the connection between varicocele and male subfertility is not completely understood, but we do know that varicocele repair can improve sperm parameters and pregnancy rates. In this specific patient with 2% normal morphology, but the remainder of his semen parameters within the normal range, he is considered to have isolated teratozoo-spermia. This is defined as less than 4% morphologically normal spermatozoa. Now, the American Urologic Association and the American Society of Reproductive Medicine have guidelines outlining the criteria required to proceed with varicocele treatment. They are the following. Number 1, the varicocele must be palpable, so either grade 2 or grade 3 clinical varicocele. Number 2, the couple should have documented infertility. Number 3, a female should have normal fertility or potentially correctable infertility. And number 4, the male partner should have 1 or more abnormal semen parameters or sperm function tests. However, there is a caveat to these guidelines, as there is significant controversy regarding the predictive value of isolated teratozoo-spermia. In fact, some may argue against using isolated teratozoo-spermia to make any treatment or management decisions. However, in my clinical practice, we have found that varicocele repair does and can improve semen parameters. This includes morphology. There is also data to support these findings. Furthermore, we counsel patients on the potential of avoiding assisted reproductive techniques or downstaging the required assisted reproductive technique that may be required after having a varicocele repaired. So to answer this specific question, in a patient with isolated teratozoo-spermia, he does meet these 4 criteria, and I believe a varicocele repair is a good option. Question number 2. We have a young 17-year-old male with a grade 3 varicocele. He has 10 million sperm per milliliter, 20% motility, and over 6% normal sperm morphology. Is he a candidate for varicocele repair? So this is a young adolescent with oligoacinozoospermia. Fortunately, the AUA and EAU guidelines have discussed the role of varicocele repair in the adolescent population. The biggest risk in this population is overtreatment, as many adolescents with a varicocele will have no problem achieving pregnancy later in life. However, there are 2 conditions that that can help you decide on whether a varicocele should be performed. This includes impaired semen quality or a growth deterioration of the testicle or abnormal size as documented by serial clinical examination or scrotal ultrasound. So in this particular patient with an abnormal semen analysis, it is reasonable to offer varicocele repair. Now, if this were a patient with normal semen parameters and a normal physical exam, I commonly recommend reevaluation at 1 year or at 2 years with both physical exam plus or minus a semen analysis to assess the semen parameters. Let's move on to question number 3. We have a patient who presents with a sperm concentration of 40 million per milliliter. He has 50% sperm motility, but his morphological examination showed all sperm without an acrosome. What are the chances of successful pregnancy in absence of female factors? So this is a patient who has Globus Zoo Spermia. This is defined as sperm without an acrosome, and this is a rare genetic etiology or condition with an incidence of less than 0.1%. Men who present to the clinic typically have a normal physical and clinical characteristic. They have normal mental development, and they have a normal hormonal status. Unfortunately, the only viable treatment option for this patient is IVF and ICSI with or without oocyte activation. Dr. London in 1994 was the first to report a clinical pregnancy and delivery after a second cycle of IVF and ICSI. Fertilization rates are poor, roughly 12 to 30%, and these patients have a higher rate of fertilization failure than IVF ICSI performed for other causes. Question number 4. A patient presents with sperm concentration of 30 million per milliliter and 60% motility. The morphological examination showed all sperm were of round shape or Globus Zoo Spermia. How will you manage this patient? So just as we discussed in the previous question, these patients typically present with normal phenotypic characteristics and a normal hormonal profile. However, IVF ICSI is the only viable treatment option. So these patients should be offered genetic counseling and strongly recommended to evaluate the risk of transmitting a chromosomal defect or a genetic mutation when they undergo IVF ICSI. There are no reports of recurrent constitutional chromosomal anomalies in patients with Globus Zoo Spermia. Question number 5. So we have a patient who presents with 50 million sperm per milliliter, a 50% motility, but 0% normal forms. How will you manage this patient? So this is a very common clinical scenario. Fortunately, we have a good working relationship with our reproductive endocrinologists, and they commonly refer male patients to our fertility clinic for further evaluation. In the past, many of these couples have been pushed to pursue IUI or IVF ICSI due to an abnormal morphology on the semen analysis. However, recent data does not support this practice. In fact, the majority of proven fertile men had sperm morphologies values in the abnormal range. Given this fact, it is very important for patients to be evaluated in the clinic and have a complete history and physical exam. Furthermore, we must discuss timed intercourse prior to proceeding with any sort of assisted reproductive techniques such as IUI or IVF. Because of the controversy and the predictive value of morphology, timed intercourse would be the next best step for this patient. If you look at this slide, there was no significant difference in IUI pregnancy rates for couples with severe teratozospermia compared to controls with normal morphology. This is also demonstrated in patients who underwent IVF ICSI. So men with severe teratozospermia, there was no difference in IVF ICSI outcomes. A meta-analysis of studies from 1986 to 2009 failed to find a relationship between sperm morphology and clinical pregnancy rates with IVF or ICSI. So again, going back to the fact that these patients should be advised on timed intercourse. We should also assess them for any modifiable risk factors such as smoking, lack of exercise, alcohol intake. We can also consider assessing their oxidative stress status and may offer antioxidants as a potential treatment option. However, much can be done before pursuing any sort of assisted reproductive technique in this particular scenario. Moving on to question number 6. We have a couple that is trying to conceive via IUI. There are no female factors. The sperm morphology is only 1%. What are their odds of conceiving compared to another couple with 15% normal sperm forms? So again, similar to the previous question, that there has been no statistical difference in IUI pregnancy rates among patients with varying morphology results. No significant difference in IUI pregnancy rates for couples with severe teratospermia compared to controls with normal morphology. So for this particular couple, the important thing is to reassure that this patient that timed intercourse is also an option, but if they would like to pursue IUI, their odds of conceiving are no different than a patient with 15% normal sperm forms. I find this very an important fact because of the stress that this may have on these patients. Many of these patients are referred from other practices or institutions and are told that they have no normal shaped sperm, and this can be very distressing. However, it's important to explain the statistics and the studies to these patients to help alleviate some of these stressors, which stress can also have a negative impact on fertility as well. Now finally, question number 7. We have a patient who had a semen analysis done in China in 2018. He then saw an infertility specialist at the Cleveland Clinic in 2019, and we can see both semen analysis below. So you can see similar semen concentration, 30 million and 28 million per milliliter respectively, 50% motility versus 45%. The main difference here is in morphology, 15% initially and now 2% on the most recent semen analysis. How would we manage this patient? So, as you may have already gathered from the previous lectures, there's significant inter and intra-observer variability when it comes to not only morphology, but the semen analysis. So that is why we find it very important to repeat the semen analysis for any patient that comes to our clinic, and we like to separate it by approximately 1 month if possible. I would obtain a complete medical history and physical examination for this patient, again looking for any modifiable risk factors that we can discuss, and would also offer sperm DNA fragmentation or some other sort of advanced sperm testing, as this patient has been having infertility for roughly 1 year of time at least. Prior to offering any sort of assisted reproductive technique or donor sperm or adoption, it's important to review that these patients were performing timed intercourse appropriately. And once you have taken all the steps in the workup and management of a male infertility patient, you can then also offer and discuss any sort of assisted reproductive technique or donor sperm or adoption. This concludes our lecture today on the clinical evaluation of sperm morphology. I hope you found this useful, and if there's any questions, please do not hesitate to contact me. Thank you.
This is our group at Cleveland Clinic in Andrology Center, and this is one of the images of the Cleveland Clinic. And you can connect with our program. We are posting daily our research activities, large number of research articles. You have free access to all these publications that we are offering. We are also sharing our latest research presented at ASRM, which is American Society for Reproductive Medicine, European Society for Human Reproduction, American Urological Association. Also, you can learn about our research opportunities and ART training, which are online ART training and opportunities to collaborate. You just have to find me on LinkedIn, Ashok Agarwal Cleveland Clinic, and you can send a request to join.